Welcome back. We'll continue our look at cardiac regulation and the cardiac output through stroke volume and see how this is going to relate back to our cardiac output. So stroke volume itself is something that is going to be related to the amount of blood that is being ejected from the ventricles. And so a couple of things are going to have an influence on how much blood we have to be able to contract out of, or to push out of during that contraction. One of which is how much blood gets back to the heart. And so as we have blood returning from the venous side of the system, how much is actually entering in from the actual atria. And so how much is coming back in from the return from the system, how much are we getting back from systemic circulation, how much is coming back into the ventricles. So how much do we load it in the beginning? What we call preload is the amount of blood in the ventricles at the end of diastole, so at filling. So how much, in a sense, did we, if we had our ventricle here, say, and we started out after systole with a certain amount of blood in the heart itself, and then after we filled it during diastole, how much blood is there? What's our preload? How much did we actually, in a sense, kind of stretch the heart out? How much did we add to the volume inside that ventricle itself? And so how much are we going to be able to potentially contract again during our next contraction and get that blood back out? Can we get it back down to the same amount? And then we have our difference there in our end diastolic volume and our end systolic volume, which is going to equal our stroke volume. And so one of the things when it comes to stroke volume is we have to look at the end diastolic volume, and then we have to look at the end systolic volume. Oops. So compare the two, and that's where we then come up with our 70 milliliters or so per contraction. And so per heartbeat, per contraction of the ventricles themselves. This can be altered by things like the autonomic nervous system. And so our parasympathetic or sympathetic control of the heart has an effect on what's going to happen within that return and the changes that are there, how much strength of contraction there is, things like that. We also have afterload. And so afterload is not really related in a sense to what's happening inside the heart itself, but it's actually what's outside of the heart. And so when we're contracting the heart, I'll just draw a little heart here, and we have our vessels going out of the heart, and so the aorta here, the blood that's inside the heart exerts a force within those vessels themselves. And so when we want to pump the blood out and into there, we've got to essentially force it into that blood that's already contained within. And so it's the resistance of the arteries when the blood is being pushed into those arteries themselves. Think of it as kind of like blowing up a balloon, something like that. And so that resistance that is being pushed on by the balloon itself, if we've never blown that balloon up before, it's harder to get it going in the beginning. It's got essentially a greater afterload. But once we stretch out that balloon a little bit, our afterload decreases and it makes it easier for it to go in. And so the amount of pressure that's inside here, and so our blood pressure at that particular time, if it's increased, we're going to have an increase in afterload. If it's decreased, we're going to have a decrease in that afterload. And so it depends upon what's going inside there in the vessels themselves. So preload is that amount of blood that's in the ventricles themselves, what's ready to be ejected from the heart with the next incoming beat itself. And afterload is, as this one here shows, it's kind of like if we increase the pressure. So if we have vasoconstriction, in our blood vessels out in the periphery, then we're going to have an increased afterload. And so it's going to be harder to get that blood in there. If our afterload is increased, that means the heart's going to have to work harder and stronger to pump that blood through that little constriction, in a sense. Here we have a constriction, or through all of those vessels that are vasoconstricted themselves. And so that's going to determine also what our eventual blood pressure is. And so that's going to lead to a change in the blood pressure based upon these effects as well. Afterload themselves is oftentimes more prevalent in the elderly because they may have the effects of atherosclerosis. And atherosclerosis is going to cause the blood vessels in the arteries to develop, let's draw a little artery here, to develop little plaques on the inside of the arteries. And those little plaques on the inside of the arteries can make it harder to get blood to move through them. And so as the blood is trying to get through there, it's got more resistance, it's got more things that it's bumping into, and so the pressure goes up in those blood vessels, makes the blood vessels effectively harder as well as narrower. And so the arteries now have an increase in our peripheral resistance. And so the peripheral resistance now starts to go up, and it makes it more difficult for us to get that blood to start to go through there. We'll talk about that more when we get into the blood vessels and blood pressure as far as that resistance goes and how it affects blood pressure itself. So that means since we have these more difficult blood vessels for blood to move through, it's harder for the heart to push through them. And so it's kind of like, rather than having a blood vessel that is kind of elastic and can kind of balloon out a little bit, the blood vessels themselves remain rigid. And so with this one, it's going to take an increase in blood pressure in order to get the blood to go through there. An increase in blood pressure in this case is going to also mean an increase in force from the heart. And so our contraction is going to be more forceful. This one, blood pressure is decreased, and we can have a decrease in the force. So we can change that with those as well. As we fill the heart, and so as we increase that preload on the heart, that increasing preload causes the heart itself, just keep going with my little hearts here. So as we increase the size of the heart and fill the heart itself, that means that it's more stretched out. And as that stretch increases, it's kind of similar to that of like a rubber balloon again. And so if these were all rubber balloons and they have the little part that we blow into here, and we let that little part and allow for the air to come out of there, which one's going to have the greatest force? Obviously, the larger one has more pressure inside there. It has more stretch in the rubber of the rubber balloon, and it's going to fly all around the room a lot more. Versus our smaller blown up one, our smaller one, is not going to blow around very far. It's not going to do as much kind of crazy flipping and flopping around. And the same thing kind of goes to the heart, except that we're changing the contraction of the heart. And so with an increased venous return, where we've now got more preload, that stretches the heart. So we've got more stretch on the heart, which is going to lead to an increase in contraction. So we're going to have a stronger contraction, and that's going to lead to a stronger stroke volume. And so think about it in terms of this way. If we've got, we'll change it over to red for our blood. If this is our end diastolic volume, end diastolic volume that is there, and we go and we have a muscle contraction in there, and we have an end systolic volume down here, we've got to get to that same place. Now, if we increase our venous return, and all of a sudden our amount of blood that we have is now way up here, In order to get back to this point here at our end systolic volume, we need to have a greater, stronger contraction. So this is our normal end diastolic volume. This is our normal end systolic volume. And that usually, the difference between the two, usually gets us 70 milliliters. This other one over here, we've increased it all of a sudden, and now our output, maybe in a sense, because I kind of doubled it there, is going to be 150 milliliters. And so we're going to have a much stronger contraction in order for us to get back down to that same end systolic volume. So as we change things, the sympathetic nervous system has a role as well. It's not just kind of simple reflexes and things like that as well. And so as sympathetic activity increases, so as we change those controls there, we have our strength of contraction increasing. So this is our extrinsic control. We're controlling it from outside of the heart itself. If we had an increase in venous return, we would end up with a increased strength of contraction. Same thing with the end diastolic volume that we just looked at in the other side. So if our end diastolic volume goes up, that's going to lead to more stretch. More stretch leads us to a positive influence on strength of contraction, which then leads to a positive influence on stroke volume. If all of a sudden we say, okay, sympathetic activity go up, we need a stronger contraction, but we don't have an increase in venous return, our stroke volume is not going to be enough. And this is what sometimes happens when we do things like stand up too quickly. We don't change the other forces on there, and so we don't get the same output that's there. So our total cardiac output is always going to rely upon heart rate and stroke volume. So heart rate times stroke volume equals cardiac output. That's going to be our factor in terms of determining what that is. And so we said that our normal was 75 beats per minute, 70 milliliters for our stroke volume equals a cardiac output of 5.25, I can't write today, liters per minute there. So we end up with a little over 5 liters per minute coming out as our overall cardiac output. So lots of different influencers into the process of getting our cardiac output itself. Some things can affect the heart rate. Some things can affect the stroke volume itself. And so either our parasympathetics or sympathetics. Parasympathetics going to bring our heart rate down lower. Sympathetics going to bring our heart rate up from our baseline. Venous return, more stretch on the heart, is going to lead to an increase in diastolic volume. If systolic volume had gone down and systolic volume had gone down the last time, that may remain relatively flatlined there for those things. But that is going to lead to an increase in cardiac output by an increase in stroke volume. Sympathetic, same thing. If that heart rate goes up and also increases contractility on the heart, that's going to then increase stroke volume. And an increased heart rate, an increased stroke volume leads to an increase in cardiac output. And so all of that leads to a greater function there in the heart itself as far as where that goes. And depending upon what we're doing is going to dictate how much that cardiac output is, as well as where it goes. And so if we start to exercise, and so we start to go run around, we start to lift weights, things like that, our cardiac output is going to go up based upon those factors that we have going on in the body itself. And so things like our muscles are going to be working more, and as such, they're going to see a huge amount of change, positive change in the overall percentage of blood flow to them. They're also going to see a huge change in the amount of cardiac output that is sent to them as well. And so those are going to change in terms of where they're going. If we're working out, we're more in a sympathetic state than in a parasympathetic state. So we expect that things like blood flow to the digestive tract, to the kidneys, is going to decrease a little bit. We're going to have that change there. One place that may sound kind of weird that it goes up is the skin. But remember that the skin is going to be our way of cooling off. And so the change there is going to be in the skin to help with those cooling effects that are there. One place that basically needs to always stay the same is the brain. And so the brain's going to have roughly the same output to it as it is during any given time. So it's going to have the same demand upon it that we usually do. Heart's working harder to get that blood going, so its output is going to go up as well. And so we're going to see an increase in blood cardiac output percentage going to the heart compared to that at rest there. And so we can change where the blood goes at any given time and make those alterations as are needed for making sure that those different processes are able to have adequate amounts of cardiac output to them.